Good afternoon, and welcome to Oral Health Care at Any Age, a free Zoom webinar that's part of the Lunchtime Learning Series hosted by the University of Delaware's Center for Disability Studies. Thank you for joining us. I'm Victor Schaffner, the Center's Director of Communications and Advocacy. During today's hour-long event, you will learn about Delaware Medicaid's new dental benefit and the ways in which it marks progress toward oral health equity. Stephen Groff, Director of the Delaware Division of Medicaid and Medical Assistance, and Lisa Zimmerman, the division's Deputy Director, will be presenting. After their presentation, we will pose some of your questions to Steve and Lisa. There may also be opportunities during their presentation to ask them a few questions. So during our hour together, simply enter your questions into Zoom's chat field, and I or Zach Davis, also with the Center for Disability Studies, will pose several of them to Steve and Lisa after their presentation. Lastly, at the end of the hour, we will email to all of you who registered for today's event a brief evaluation form. We ask that you take a moment to complete it and return it to us. Thank you, and with that, I'll turn things over to Steve.
So good morning, everybody, and thank you, Victor. First of all, let me apologize. I live in a rural area and my internet leaves a little to be desired. So my lips, my face may not match up with what you're hearing, and that can be a little disruptive. And again, I apologize for that, but I hope that you all can at least hear me well. I'd like to take this opportunity to thank the Center for Disability Studies for inviting us to have this webinar today. And I'm absolutely thrilled to see the engagement and participation. It looks to me like we have close to 80 participants right now on the phone. The reason I'm so happy about that is because this is a really important benefit for us and something that we in Delaware have waited a long time for, as I know you have as well. I will be giving a presentation, but I will be honest with you. One of the things that has been challenging for me during COVID is I prefer a dialogue. And that's sometimes challenging to do in a remote setting, but I really encourage you to ask questions because while I can provide some basic information about the history of this and the benefit itself, I know that doesn't actually provide you with some of the information that you need or respond to some of the questions or concerns that you have. So please do enter your questions because I really think that's the most important part of an opportunity like this. So an adult dental benefit in Delaware is something that, as I said, we have waited a long time for. For those of you who are not entirely familiar with the way the Medicaid program works, it is a federal-state partnership. So there are certain mandatory benefits that we must provide in order to participate and comply with federal regulations for the program. And then there are optional benefits which states are allowed to provide with federal approval. When it comes to oral health care, for children, this is a mandatory benefit. And so children under the age of 21 have always had access to a comprehensive dental benefit through the Medicaid program. But for adults, it's an optional benefit. And an optional benefit that Delaware has not in the past provided. Other states do provide an oral health benefit. And there's a wide variety of what that looks like in states. Some states provide just an emergency benefit, so that if someone were to, say, appear in an emergency room with a dental emergency, that treatment would be covered. Some states provide a preventative benefit, basically just cleanings and exams, or a capped benefit, um, which is what you'll be hearing Delaware has done. And some states offer a comprehensive dental benefit, which does not apply caps like we will be doing here in Delaware. And then for the longest time, there were 3 states who had no oral health benefit at all, Delaware being one of them. But I think we now have the adult dental benefit. If I'm not mistaken, I heard my colleague in West Virginia say that they were rolling out a benefit. So hopefully we will see adult dental benefits nationwide shortly. The reason that we have not provided a benefit is not because we didn't think it was important. In fact, I can say I've been the Medicaid director for 8 years, and this has been on my priority list each and every year. We understand the importance of oral health as it relates to comprehensive health care. We understand that there are benefits beyond just the medical benefit that relate to emotional and mental health well-being. We understand the importance of these benefits in allowing people to be able to pursue employment. And we recognize that a large segment of our population, as they transition from childhood to adult, really felt a gap in coverage when those benefits were no longer available to them. So we have advocated for this for some time. We have had many champions in the state of Delaware also advocating for this, including our lieutenant governor, including members of the legislature. The holdup has always been a financial concern. It is very difficult to, within the budget constraints, to find the resources to expand our program beyond the mandates. While it certainly is clear to everyone that the absence of dental care can result in much more expensive healthcare costs due to the deterioration and physical health impacts that result from the lack of dental care. That's on an individual basis. The cost of extending a dental benefit to the entire population is more expensive than the savings associated with those individuals who experience adverse health consequences of the lack of care. And while that may sound a little harsh, that is the fiscal reality of it. So we were never able to introduce this program without a fiscal note, without a budgetary impact. And we were very fortunate that several years ago, with the assistance of Senator Townsend and Representative Bentz and others in the legislature, we were finally able to get legislation passed that would allow us to introduce the benefit. In fact, I was extremely pleased when I went down to Dover to testify on behalf of the legislation that there was absolutely no opposition to it. So everybody really understood the importance, and when the funding became available, we were able to have that legislation passed. Now, originally the benefit was supposed to have rolled out in April of 2020. And while that was a very aggressive timeline, with regard to getting anything up and rolling in the Medicaid program. We really felt and believed and hoped that we were going to be able to meet it. Unfortunately, as we got very close to April 20th, we found that there were still some issues around getting our final federal approval, which is required before we can introduce a new program. And we were hit with the COVID pandemic, which really required all of us to pivot, both here at the state level and on the federal level, to have really all hands on deck addressing the pandemic. But we were supported by the legislature and others in getting an extension until October 1st of 2020. And we worked very, very hard with all of our partners to make sure that we were ready to go on October 20th. And when I mention partners, I really would be remiss to not express my appreciation for the collaboration we got from so many people and so many partners in making this happen. Not only our federal partners at CMS, but our managed care organizations who I'll be talking a little bit about in a few minutes, who are assisting us in administering this, from the stakeholders, many of whom are in the audience right now, and from the dental professionals in the state of Delaware, our providers, and most notably the Dental Society, which really worked with us hand in hand to help us understand what barriers might exist, what challenges might exist, and to help us make sure that we had a provider network in place, because simply offering the benefit or offering the coverage does little good if people can't actually get appointments and get the treatment that they need. So I hope that's somewhat helpful in helping understand the background. If we could go to the next slide, please. So this is just talking a little bit about what I hope to cover today. I'll be talking a little bit about what exactly the covered services are in the benefit, what the limits are when we talk about a capped benefit, how the MCOs will be assisting us in rolling this out for adults, and how that differs from what you may have experienced if you participated or your children participated in our child benefit, how you can find a dentist, and then a very quick update on what we've seen as far as utilization to date. So if we could go to the next slide, please. So here is generally what our covered benefits are. We do have the preventive services included, exams, x-rays, cleaning, and fluoride. In the way of treatment, restorative services, including fillings, periodontics, oral surgery. One of the questions that I get asked very, very often is whether or not sedation is covered. It is. So if an individual requires sedation in order to undergo dental treatment, that is a covered benefit. I guess the question that I get asked most after sedation is dentures. I am sorry to say that dentures are not currently a covered benefit in the program. Although denture repair for individuals who already have dentures is covered. The reason for this is really has no basis from a policy or programs standpoint. It is strictly a financial constraint. We simply, within the dollar limits that are allocated, can't at this time offer a full dental benefit, which would include upper and lower, and perhaps the treatment that would be required beforehand, whether that be extractions in order to prepare the mouth for the dentures. So we are continuing to look at this, and there is no statutory prohibition from us including a dental benefit. It is, as I said, strictly a financial issue, and we will continue to look into that and explore options for how we might be able to expand in the future to cover dentures. If we could move to the next slide, please. Thank you. So the dental benefit itself, there is an annual limit of $1,000. And what that means is that people are entitled to $1,000 worth of treatment. With few exceptions, there are not prior authorizations for that treatment if it's a covered benefit. And that would be a matter of working out a treatment plan with your dental provider. Once that $1,000 is exceeded, then there is an emergency dental benefit category that an individual can move into. But otherwise, there would not be any additional dental services available to the individual until the next benefit year. January 1st of the next year, that $1,000 would again be available to the individual. And so we encourage people to work with their dental providers, their dentists, where possible, to develop longer range treatment plans where perhaps services can be received this benefit year and others might be postponed until the next benefit year when that $1,000 is replenished. For individuals who have already hit the $1,000 mark and experience some type of dental emergency, and on the next slide, we'll find that can be one of two things. There is an additional $1,500 that can be accessed. So there are two things, or two general categories that we consider an emergency in our program. One is an unforeseen or sudden occurrence that really demands immediate action. And without that immediate treatment, there's the potential for a serious health risk or a rapid decline in oral health. In these cases, prior authorization is not required. A dental provider should go ahead and initiate the treatment and submit the claim for payment with the medical justification afterwards. In other cases, it may be where an individual's dental needs are so extensive that it will exceed the $1,000 cap. But it really is not prudent to delay the additional treatment until the next benefit year. And in this case, the provider would be asked to submit a prior authorization for medical necessity, and that would be reviewed, and if approved, then that dental treatment plan could be initiated to offer those additional services. Next slide, please. So, as I said, prior authorization is required unless an emergency exists. Enough said on that. So to the next slide, please. So here's where our program differs from the children's dental program. In Medicaid, we have two general categories of service delivery. One is what we call fee for service. And that basically refers to a program that is administered by the Division of Medicaid and Medical Assistance, as opposed to one of our managed care organizations, and where providers submit their claims directly to our fiscal agent. Many of you know them as DXC. They recently changed their name to Gainwell. But basically, that is the agent for the Division of Medicaid and Medical Assistance, and we pay those claims directly. The other service delivery mechanism is our managed care organizations. And in that case, providers would enroll with the managed care organizations and submit their claims to the managed care organizations, who pay those claims on behalf of the Medicaid program. The children's dental benefit has always and continues to be a fee-for-service program. So when children receive dental services, their dentist would bill us directly and we would pay the claim through our fee-for-service program. The adult dental benefit will be administered by our managed care organizations. So providers will enroll with each of our MCOs. Individuals who are enrolled with their MCO can access the benefit and a dental provider through their managed care organization, and claims will be submitted and prior authorizations will be submitted through their managed care organization. There will be a time for people who newly enroll to the program, where you are enrolled in fee-for-service while your enrollment in managed care is being completed. During that time, adults can access the dental benefit through our fee-for-service program. I don't want to confuse people, although I'm sure I already have, but that just means that regardless of the status, your status, whether you are enrolled with our managed care organization or you are in our fee-for-service program, you will have access to the dental benefit. For any providers on the call, the contracted MCOs have been or are required to follow our fee schedule for at least 1 year. So the payment will look the same, whether you are getting paid by Highmark Health Options, AmeriHealth, Caritas Delaware, or the Delaware Fee-for-Service Program. Your payment for a covered service will be the same. If we could go to the next slide, please. So each MCO has a network of contracted dentists. And if you are enrolled in an MCO, you will need to contact them or look at your benefits materials online to see which dentists are enrolled with your MCO. Those dental provider networks will be different depending on the managed care organization. Dentists can enroll with either or both MCOs with our fee-for-service. So as I said, you would need to contact your MCO to find the right provider. If you need assistance with transportation to your dental visits, that is a covered benefit through the Medicaid program. And you would continue to access transportation services through our transportation broker. If you need prior authorization, or if a dentist needs to request prior authorization, again, that would be through the managed care organization. If we could go to the next slide, please. So here are your options if you need help in finding a dentist. There are phone numbers here for Highmark Health Options, AmeriHealth Caritas Delaware, and please let me note here that there are two numbers, one for those who receive additional long-term services and supports who are enrolled what we call the PLUS program, and for those who are in the basic Medicaid program, just the Diamond State Health Partners. And for those who are not enrolled in managed care, then you can go to the website link that is posted here for assistance with our fee-for-service program. If we could go to the next slide, please. So this is, as I said, some basic information on what we are seeing. And I have lost, I'm not sure what I did. But I'm not going to worry about it. I'll get back to that later. Basically, we have been very happy with both the provider enrollment and the uptake in the program. I will be honest with you, we did have concerns about the availability of services, especially in the pandemic. But in the first quarter that the program has rolled out, over 4,300 adults have received dental services through our program. And we have expended $1.9 million in provider payments. So we see that as a good start. We know that there is room for improvement, and certainly wanting to hear what your experience has been, and if you have experienced any barriers or challenges. I'm going to probably give Victor a little bit of palpitation here because my presentation is officially over and we are still early in the webinar. But I truly am hoping that we will have questions because that is how we learn what we are doing well, what we are not doing well, what we need to better communicate to people. And I'm really hoping that we can engage in some what of a dialogue here.
Well, thank you, Steve, very much for the background on the program and its benefits. And now Steve, with the support of Lisa Zimmerman, will be available to answer your questions. Any questions that you do have, simply enter them into the chat field, and Zach Davis will be happy to pose them to Steve and Lisa. Zach, what do you see?
Hello. So no worries, Victor. There are plenty of questions. So not too many palpitations, I hope. The first question, Steve, if you've seen about $1.9 million of expenditures in a quarter, which goes up to about roughly 8 million a year, is there concern that that's overshooting the $5 million per year estimate in the fiscal note for how much this will cost?
No, I would not say that I am concerned at this point. There are actually a couple of things to consider. One is we expected, notwithstanding the pandemic and perhaps access issues, which I'm happy to say we did not see, we expected our first quarter to be pretty robust because of pent-up need. So we were expecting that we would see, and especially with it rolling out in the last quarter of the benefit year, people trying to, and providers trying to assist people in developing treatment plans to get as much work done as possible in that quarter before the end of the benefit year. I will say that we always go into these new expansions or new rollouts with the understanding that our fiscal estimates are exactly that, they're estimates. The Medicaid program is an entitlement. Once we offer a benefit, we cannot limit it based on the availability of funds. So we try to get that number as accurate as possible. But I don't want anyone also to feel the concern that, you know, at some point during the year, if we approach that number or hit that number, that we would then shut the benefit off. That's not how the Medicaid program works. So we will continue to track this and include you know, our experience in future budget projections, but I would say we're quite pleased with what we're seeing.
If oral surgery is covered by medical insurance, will Medicaid cover the copay regardless of provider?
So I want to make sure I understand this question. First of all, that's an important thing that I did not cover regarding Medicaid. So let me talk about Medicaid copays first. The legislation requires that we impose a $3 copay. There are some adults who federal regulations exclude from any Medicaid copay. But for those who are not excluded, there would be a $3 per visit copay for the Medicaid program. That is currently suspended because we have suspended all Medicaid copays during the public health emergency. I am interpreting this question to refer to an individual who has primary health coverage other than Medicaid, where Medicaid would be the secondary payer, and that their primary payer has a copay or some type of cost sharing. I will confirm this and get you a written response. Normally, if someone has primary coverage, Medicaid will pick up all or some portion of the cost sharing that's associated with that primary coverage. And my belief is that that is the same with our dental benefit. But let me confirm and make sure that I'm giving you the accurate response.
So questioner, the questioner responded, that is the correct interpretation of her copay question.
Good, thank you for that.
So next question, could you explain the transportation again, please?
Okay, so one of the services that is covered for Medicaid beneficiaries is what is referred to as non-emergency medical transportation. So we understand that many people may be challenged in their ability to get to a doctor's appointment. And so one of the federal requirements in the program is that we assure that people who do not have access to transportation can be provided transportation to make sure that they are able to get to their healthcare appointments. And this includes dental appointments. So in Delaware, the way we administer that program is we have what we call a transportation broker. Many of you, I'm sure, are familiar with Logisticare. They recently rebranded and have a new name, and I'm so sorry that I don't know what it is, but I will share that as well, because I'm sure most people still know them as Logisticare. Logisticare is responsible for contracting with providers who actually provide the transportation. They are also responsible for scheduling appointments and with transportation providers and members to get them that transportation. So we do have information on our website, and I will share with you as well so you can get it out to everyone. But if somebody needs, and thank you, Lisa, you could have spoken up. She just texted me the new name for Logisticare. It is Modiva, Modiva. But the procedures are still the same. You would call them, you would let them know when your dental appointment is. They would assist you by scheduling a provider who would be able to provide transportation to and from the appointment so that you can receive the dental care that you need.
What determines which MCO a patient is covered by, and is there any difference between them?
So individuals may enroll in either of the MCOs. Each MCO is required to provide the full range of Medicaid covered benefits. So from that perspective, there is no difference. MCOs are allowed to provide optional benefits. So you would need to look, and that this information is available through our health benefits manager. We can share that number as well. Which, if any, optional services MCOs may provide. MCOs will also have different provider networks. So if you have a dentist or an oral healthcare provider and you want to retain that individual, you should certainly check to see if they are enrolled with either or both MCOs. Each year, once a year, we have an open enrollment period where individuals can switch from one MCO to the other if they wish to do so for any reason. During the year, individuals can switch if there is a good cause. Good cause can mean your provider is in one MCO and not the other, or your provider leaves one MCO but is still enrolled with the other. If you have any questions about enrollment in the managed care organizations, or feel that you have a reason to want to switch and want to see if you're eligible to switch, as I said, we will provide information on the health benefit manager, and individuals should call them with their questions and to get assistance.
This question comes from a practitioner. We work with special needs patients / DDDS patients, some of whom cannot get any work done in the office. For many of them, we are unable to know what emergency or dental care they may need prior to being seen in the operating room for sedation. What would the best way be to go about accessing the additional emergency funds for these patients?
Okay, give me a minute to break that down. First of all, I want to thank those providers who have provided services to some of our members with disabilities, and I know there has been a strong partnership with the Division of Developmental Disability Services, and we are greatly appreciative of that. I also know that there may be questions about how we are going to coordinate with DDDS, and if you have those questions, please send them on to us. Basically, for our members who are enrolled in both Medicaid and served by DDDS, we encourage you to access our benefit first. but continue to know that DDDS may be an available resource to assist with supplemental needs or needs that are not in our covered benefit. Now to the emergency benefit. I'm a little unclear as to what exactly we're asking. So we understand the challenges with serving individuals who may be unable to sit in the chair or handle the dental service without the need for sedation. But I'm unclear as to why we would need to immediately move to the emergency benefit and why that initial visit, exam, and treatment planning couldn't occur within the initial $1,000 benefit that requires no prior authorization. So I don't know if
the
they could help.
the questioner expands. Basically, we don't know ahead of time anything that needs to be done, so we could never pre-authorize these visits.
Okay, and so and I'm assuming then that the questioner believes that or feels that we would get somebody in for an initial visit. We would identify the need for more than $1,000 worth of work, which could be done during that visit and would probably be the preferable way to do that rather than try to bring the individual back for another visit. Why not get the work done all in one sitting while we have the person there in the chair and not make them come back? Would that be correct?
Yes, the questioner adds further, they're always over the $1,000 limit.
Okay, good to know. So I don't have a good answer for that other than to say I think that's an excellent question and not one that we have heard. And so what I will do is I will take that back and work with our team and the managed care organizations to see how we address that, because I certainly understand what I'm hearing, and it's just not a scenario that we had discussed.
The questioner says, once we sedate them, we try to get as much work done as possible so as not to have to sedate more than once.
And that certainly makes sense. So again, I am interested in looking into that, and we will get back to you with follow-up. Thank you for the question and the clarification.
When a child reaches age 21, how does that child transition to adult benefits?
So the benefits, the coverage is available. You don't have to do anything to transition. Just like as an adult, you don't have to do anything to enroll for the benefit itself. But I see that Lisa has shared in the chat the number for our health benefit manager. Thank you, Lisa. So you don't have to do anything to have the coverage or to have access to the benefit. But if you are moving from the children's program to the adult program, the one thing you would need to be concerned about is access to your dentist. So I'm assuming you already have a dentist, and you would want to keep that dentist unless there is some type of, and I'm not a clinician, so please excuse me if I get any of this wrong, but I believe that there are dentists who specialize or pediatric dentists, so you may need to move from a pediatric to an adult dentist. But assuming that you want to keep your dentist, what you would need to do is check to make sure that your dentist is enrolled with the managed care organization that the transitioning child is enrolled in. And then perhaps make a change if you feel that you would prefer to be with the other managed care organization, if that's necessary to retain your dentist.
So what would happen if an individual went to a dentist and it became clear early on they needed more than $2,500 worth of dental care? An individual covered by Medicaid.
So at this point, I'm happy to say that hasn't been the case. We are limited to the $2,500. So I would say that what we would do in that situation is we would want the provider and or the individual to reach out to the managed care organization or us and help us to understand that situation. And the reason I say that is for two reasons. One is we certainly would want to work with the provider and the managed care organization to see what we could do to develop a treatment plan that would meet the needs of the individuals, but would also be within our financial and budgetary constraints. But secondly, we are collecting information on the adequacy of the benefit for evaluation purposes and for future planning. And so to the extent that we find that the 2,500 is inadequate in some cases, we want to better understand what that looks like and why for future planning purposes, if in fact there is any opportunity to expand the benefit in the future.
Zach, I just want to jump in with a couple of questions here, and then we can return to what you have as well. Steve, how does Delaware's annual dental benefit of $1,000 and the additional $1,500 for emergency care compare to other states, what they're providing with Medicaid?
So I would have to go back and do my research again. If I'm remembering correctly, I believe that there were roughly 20 states that offer an emergency benefit only. So there is no treatment or routine dental benefit offered by those Medicaid programs. There are very few that have the totally expansive comprehensive benefit. So I'm ballparking here, but I'm thinking, you know, about half offer some type of limited benefit. As we were doing our research, we felt that the $1,000 limit seemed appropriate, seemed in line with what other states were offering. Some of those states may have an emergency benefit, others do not. I will tell you the holdup that we had with CMS was exactly around this question, was what they asked us to demonstrate to them, and we can pull this information and was what they termed the sufficiency of the benefit. They wanted to know our rationale for believing that the benefit limit would be sufficient to meet the needs of the majority of our members. And we used data from other states, as well as some data that we were able to get from our managed care organizations, to demonstrate to them that we felt that this limit would in fact meet the needs of the vast majority of our members. And I'm sure that that will be something that we continue to track, and CMS will be looking to us to follow up on. So I believe that we based our decision on what we were seeing, and you know, we feel pretty strongly that we're in a good place. But as I said, this is something that we will continue to review for future program development.
Okay. One other question. You mentioned earlier in your presentation about the numbers of people who so far are participating in the new benefit. And you said that you were encouraged by those numbers. How can the state, however, encourage more people who are eligible for the Medicaid benefit to access the new coverage? What are the strategies in place to extend your outreach to the public?
So one is opportunities like this, which again, I want to thank you for, because we definitely find that word of mouth somehow seems to be the best way sometimes that we get information out. We do provide information through our provider and member portals. We do also share information at open enrollment time, and we'll continue to do that with new members. We ask our MCOs to share information on their portals for their members and through their communications. I would say that despite all of these attempts and our best efforts, we find that there's always some portion of the population that doesn't get the message. And so I would certainly welcome any input on how we could do a better job, what mechanisms we might use to reach more people. And if any of you are members of organizations where you feel it would be beneficial for us to come and speak with you, albeit remotely for the time being, please reach out to me and we would be very happy to do so.
Okay, Zach, back to you. We have time for a couple more questions.
One, just piggybacking on Victor's question about outreach. Does DMMA do outreach to dental providers, or is that something left to the MCOs to join and provide this benefit?
So I would say our main avenues of reaching out to providers have been the managed care organizations for their provider networks and the Dental Society for the fee-for-service program. As I said, the Dental Society has just been an excellent partner for us, not only in making opportunities available to us to communicate directly with dentists, both before the program rolled out and as we were rolling out, but also sharing materials with the dental community with information about provider enrollment and with FAQs about the program, which I should have also said FAQs are posted on our website. Our website, I will be honest, can sometimes be somewhat challenging to navigate We have tried to highlight the information on the dental program and our FAQs, and it is there on our website. But if people have difficulty finding it, please let us know. But the MCOs and the Dental Society have been our primary means of communicating and engaging the dental provider community, Zach.
Is there coverage for orthodontics being pursued for speech deficit issues?
So this is another one where I am going to have to follow up. Medicaid, as you rightly point out, does not cover services that are considered cosmetic. Orthodontics is covered for children, but there are medical necessity criteria that need to be met. I do not believe that there is an orthodontic benefit for the adult population at this point. But I am intrigued now by the way the question was imposed. And we will go back and look at medical necessity justification for orthodontic in the adult population. Because quite frankly, I don't recall that being a discussion point as we were planning, but it certainly sounds like a legitimate area of concern. So again, I thank you for that.
Question here. You mentioned several times about looking into certain things, for example, adding dentures as a possibility. What's the process of when you're looking into something, and is there a space for public input?
So yes, the way it normally works, first of all, we welcome suggestions, comments, criticism, anytime you have it. That's how our program improves, and that's how we become aware of gaps or problems. Once we begin to look into a program or a programmatic change, before we can introduce such a change, we have to go through, if it has a budget impact, we have to go through the budget process where it would be considered both through the Joint Finance Committee hearings and through the legislative process. But also, we have to get approval. We have to request authority from the Centers for Medicare and Medicaid Services. And that requires us to go through the APA process. So that means we would submit regulatory changes to the Delaware Register of Regulations. We would have to go out for public notice. We would have to have a public notice and public input period of time, then consider any comments we receive before we could go back for, again, through the Register of Regulations for final regulatory approval.
Okay, I think if we're going to finish up on time, that will probably have to be the last question. I want to thank our audience members for their excellent questions this afternoon. I certainly want to thank Steve Groff for his presentation, and thank Lisa Zimmerman for her support of the presentation today. I also want to remind everyone who's been on the Zoom webinar today that you all will be receiving evaluation forms shortly. We encourage you to please fill them out and send them back to us so that we can receive your input on today's presentation. Also want to let you know that we will be posting a recording with captioning of today's event on our website in the coming days. So please watch for that. And also want you all to know that by the virtue of you having attended today's event, you will receive notices of future lunchtime learning events presented by the Center for Disability Studies. So thank you all very much for attending today's lunchtime learning, and have a pleasant afternoon.
Thank you.